So next, we'll have a rearrangement of the session. We'll first start with the head and neck and the recent advances, and it will be taken by Dr. Harsh, Dr. Sanjay Ghosh, and Dr. Kinshuk Chatterjee.
Okay, good afternoon. It is very difficult to discuss the recent advances in a very short period of time, within 20 minutes. So, I have selected some few questions which is very important for you, which was recent advances in my time also. I have completed my PG only 10 years ago. But the recent thing is going on, it is a continuous process. So, which was recent in 10 years ago, probably these are recent also, because these are not practiced in very frequently. So I have certain question, like some questions like transoral robotic surgery for OSA. I am not discussing it very vividly because you have to read the robotic surgery, the Da Vinci robot, everything in toto from the books. After these sessions, if you need, I can give some study materials. I will send you in your groups. So the robotic surgery is not only for the OSA, for the head neck cancers and all the laryngeals, ear, nose, everywhere, the robotic surgery is happening now. So the robotic surgery can come in a bigger questions. Second is the personalized therapy in head and neck cancer. What do you mean by personalized therapy? Anyone? So this is some immunomodulators which are used nowadays, like cetuximab. So these are the immunomodulators which can add on with the chemotherapies. Like cetuximab can act over the p53 gene or PRB genes, which are the tumor suppressor gene basically. So these things can come as a questions in your recent advanced paper, or these questions may come in your grand viva. Okay. Then the hypoglossal nerve stimulations for OSA. Do you have any idea of hypoglossal nerve stimulations? So there are some muscles are present in the tongue. Basically what happens in the OSA? What is the major treatment goal for the OSA? To increase the area over the oropharyngeal region so that the air can go deep. So there are many surgery protocols are there in the OSA in the treatment line, but along with that, the muscle tone of some involuntary muscles present inside the tongue, there's, if you stimulate by the, so there are some devices are there, it can be placed over here and it can sense your oxygen saturations, heartbeat, and along with that, when there is deep, the stimulations of the nerves and the electrodes are placed over here in the hypoglossal nerve region, and it will stimulate the hypoglossal nerve so that the muscle tonicity can maintain. It is like a CPAP techniques. Everywhere, every time you can place these things for a longer durations so that the muscle tonicity of the base of the tongue region of the tongue will increase and that will not fall down back. Okay. The current techniques is sleep disorder breathing surgery. I am not going into the details. This is the whole surgical techniques, all the surgical techniques starting from the palatal surgery, the uvulopalatoplasty, palatopharyngoplasty, and the tongue-based reductions, the advancement of the mandibles or the hyoid bones. This all will come into this region. This can come as a long question or many small portions can come as a short questions also in your paper. Now the saliva-endoscopy in the management of the salivary gland disease, this is not at all recent advance. It is used to happen for a longer duration, but it is a very hot cake and favorite questions for the MS examination in at least in our university. The robotic surgery in the head and neck, as I told you, the whole things you need to read down. The HPV in head neck cancer. Do you have any idea where the HPV will cause any head neck region cancer other than the genital cancers? Very, very good. The oral cancer, the oropharyngeal cancers, the HPV 16, and they is involved in the cancers, and how the carcinogenesis is found by the HPV. These are the details things, the carcinogenesis formations by the human papilloma virus, and what is the treatment protocol, both the prophylactic treatment along with the therapeutic treatment. Because nowadays there is a guideline has come for the oral cancer treatment. Does the HPV vaccine also act after the treatment is over of the oropharyngeal cancer when the HPV gene is detected in your biopsy material? Now, role of PET scanning in the head neck cancer. This is, you need to read through the whole of the PET scan region. What is the principle? Where are the use, the indications? What are the problems faced? What are the timing of the PET scan? And one thing you need to write down during the PET scan, because do you know what is the unknown primary? Do you know what is unknown primary? Because this is also a long question. The unknown primary, that means the secondary metastasis is present in the neck, but you cannot find the primary organs. So, to find out the primary things, what you need to do? First, what you need to do? Triple endoscopy, the pan endoscopy. You need to check the nose, nasal cavity, DNE, nasopharyngoscopy, and then the fiber optic laryngoscopy, bronchoscopy, esophagoscopy. After that, what you need to do? FNAC the first. You have diagnosed that the thing is malignant. Then search for, before the PET, what we used to do, there are some hidden areas of the oropharyngeal regions where from we can take the blind biopsy. But this is not very well established things. You do not used to do these things like the fossa of Rosenmuller, blind biopsy, the base of the tongue, the valvular region. So, to avoid these blind biopsy techniques, we now used to do the PET scan. Because in the definition of the OS, the unknown primary, the PET scan is now included. But we usually, in our current practice, usually do not do the PET scan because of the financial issue. But ideally, you need to do the PET scan before stamp it is a unknown primary. Okay. Then the mid-face lifting. Anyone has any idea of the mid-face lifting? What do you mean by mid-face lifting?
So from the mid-facial degloving approach, we can go into the anterior craniofacial resection. There are three types: type A, type B, type C.
No, that is not the mid-face lifting properly. This is a plastic reconstructions of the mid-face. What do you mean by mid-face? Mid-face? Sorry?
In rightidectomy is up to the
yes, rightidectomy is done here over here. The
একটা infrauricular, একটা preauricular,
very good. So you need to do the incisions over here, not very commonly nasolabial region. Once you need to do the incisions, what I need to do in the mid-face in a soja bangla, that is when the aging is occurring, your muscles are relaxing. And what are the muscles? Mainly muscles are over there. Major muscles is the masseter over here, and orbicularis oculi. This muscle is there. This portion is the mid-face. That means from the lateral aspect of the eye, from where to the root of the helix, this is the upper line, and the lower line is from the tip of the ear lobule to the lateral portions of the orbital commissure. Okay. So this portion is the mid-face. Now, if this portion gets relaxed, with the aging, everyone it gets relaxed and there is a suppression of this thing. Then you need to lift it so that the aging is counterfeit. Okay, so what we need to do? We need to do incisions over the temporal region, and then we need to do a flap elevations. Here the temporoparietal fascia is there, which is continuous with the mass in the face. So in this plane, we need to guide it over here. Then the muscles and the periosteum, the periosteums over the maxilla, you need to pull it over there. And from here, one most important structure is going from this region. What is this? Huh? No, the artery is not. You told probably. Anyone here? From here. The frontal nerve is going from there. Between the, just 4 centimeter away from the outer canthus. Okay. So here from, when you go through this line, then the frontal nerve may get injured. So this is the major complications of the midface lifting. Otherwise, from this tunnel is formed and then spool it with the sutures and the aging can be counteracted. So another, the free flap reconstruction in head and neck, very common questions. Free flap from very different region, anterolateral thigh from is very common, and from forehand also free flap. And what are the principles where we can use the head neck cancers region, the oral cancers mainly, the tongue cancers nowadays, because the post-op morbidity will be lesser and the functionality will be much more better. So the lateral aspect of the tongue, the hemiglossectomy portion, can easily be countered and can be managed by the free flap. Now the face transplantation, the whole of the face nowadays can be transplanted. There are some indications are there, the injuries, the malignancies, everything is there. Not for any plastic reconstruction, now face transplantation is now being done, but only for the injury and everything. This whole things is a big chapters is there, and lots of things you need to study if the questions will come over here. So the precision medicines, the immunomodulation, already I told you. The lasers in ENT, this is a big chapter also. The all types of the lasers you need to go through. I am not discussing it right. The role and the principle of the radio frequency surgery. What is the radio frequencies? The radio frequency surgery is not only used in the head neck regions, but also the nasal cavity region, the oral cavity lesions, oropharyngeal lesions. The radio frequency surgery, there is a specific frequencies of the radio frequency sound is given, and this is cut, the proper cutting and the coagulation is almost same like the coblation surgeries. Okay, just the principles are different. For coblation surgeries, there is a plasma breakdown is there, the sodium potassium is there, and this plasma cut down of the tissue without causing much bleeding. The temperature increase is likely same, 60 to 70 degree, which is just opposite to the cryosurgery. Cryosurgery, there is a freezing of the tissue is done. The water from the extracellular and intercellular fluids are frozen so that the cell gets injured and the tissue cutting will be there. Now, describe the photodynamic therapy in head and neck cancer. What do you mean by photodynamic therapy?
Photosensitive agents are used, and these sensitive agents are injected to the particular region, and then I'm going to levulinic acid.
Injected,
Then particular
it will be
light-
concentrated in the tumor tissue, and then
the patient is asked
photo. Why is this the photo?
light is given.
The specific
over the
frequency
specific
light
area.
over placed over there, or the laser light will be there, and the tissue will be destroyed. But the penetration is very less, like 5 millimeter to 1 centimeter. Not a big malignancy or cancers can be treated over there. Mainly for the oral cancer, where the mucosa, submucosa is involved, or the leukoplakia, erythroplakia, carcinoma in situ, condylomata. These things can be easily treated with the photodynamic surgery. And digital subtraction, angiography and embolization you need to go through thoroughly. And the gamma knife stereotactic surgery also you need to go through thoroughly. I am not going. Okay, minimally invasive radio assisted thyroidectomy. What is this minimally invasive? Because MIRAT or any other types of minimally invasive thyroidectomy for plastic, so that the scar is not there. Okay, so these things, and the transaxillary endoscopic thyroidectomy you need to go through. Nowadays, transoral thyroidectomy is also, specifically the vestibular type. Transoral means from the vestibules you need to go through from this region. Okay, and previously the transaxillary surgeries used to do in for a unilateral goiter, small goiter, mainly 2 to 3 centimeter. Nowadays, the total thyroidectomy can also be possible by the transaxillary. Fees you need to do. What is the full form of fees? Just I need to know. Okay. And the Cyber knife therapy and gene therapy in all the ENT, head neck cancers, these all things you need to go through as the recent advance. So I am giving the mic to the King Shuk. Okay.
Hello. Good afternoon, everybody. Thank you for the invite, AOI West Bengal chapter. I'm here to just talk shortly on the technological advances in head and neck surgery. The topics that might come in the examination has been very well dealt with by Dr. Sanjay. Hello. Am I audible in the last row? Hello. So, what I'll be talking on is intraoperative nerve monitoring in thyroid surgery, remote access thyroid surgery, and if possible, time permits, adjuncts to identify parathyroid glands. So now thyroid disease is basically a forgiving disease, but it has got unforgiving complications because we often tend to injure the nerves, injure the parathyroids, which might result in a post-operative hypocalcemia. So everything in thyroid surgery revolves around the nerves, and that is why it is utmost of importance to know why should we use intraoperative nerve monitoring, what are the types of intraoperative nerve monitoring, the clinical benefits attained, and what is the operational setup. How does it look like? So the incidence of RLN injury, the typical rates of a permanent RLN damage is around 1 to 2%. But the word of caution is the RLN paralysis rate doubles up when post-operative laryngeal examination is performed in every case, because otherwise it is often underreported. And in a study which looked into 27 articles and analyzed over 25,000 thyroidectomies, the typical rates of a total permanent vocal cord damage is found to be around 10%. So the mechanism of injury is mainly at the ligament of Bailey's area. 75% of the injuries occur there, and the mechanism by which the nerve gets damaged are these: traction, thermal damage, compression by maybe clips or when we take the knots, clamping, ligature entrapment, overzealous suctioning, and a transection of the nerve, which is the least common mechanism. And continuation of surgery on the contralateral side when there is already a vocal cord damage, as evident on the nerve monitoring system, can result in bilateral cord palsy in about almost 16 to 18% of the patients. And hence, we have evolved from an era when the nerve need not be unearthed to an era when we do see the nerve and try and preserve it. So we should always remember that a visually identified nerve which is structurally preserved and surgically preserved is not equivalent to a functional nerve. And hence is the need for the test of integrity of the nerves. So in IONM, what we do is we do an intraoperative mapping of the recurrent laryngeal nerve mainly, and to a greater extent the external branch of the superior laryngeal nerve as well. It allows us to differentiate between neural and non-neural structures. It provides an intraoperative information regarding impending injuries, and it also helps us in neurological prognostication at the completion of the surgery. So what are the types of IONM that we use? We can use intermittent nerve monitoring system, we can use a continuous nerve monitoring system. Now intermittent nerve monitoring system means we stimulate the nerve with a monopolar probe from time to time during the entire course of the surgery, and the EMG which is recorded is being displayed in a monitor which is straight in front of the surgeon. So now intermittent nerve monitoring can be of two types. Either we use a specially designed endotracheal tube which is called a NIM flex tube, NIM flex tube, which is pre-designed with 4 surface electrodes which are in contact with the vocalis muscle. Otherwise, and this is costly actually. So the tube approximately costs around 15 to 20,000. So cut down on the cost, we have another method. We can use surface electrodes. We palpate our laryngeal cartilage and we put in the surface electrodes so that it comes in contact with the vocalis muscle. So that's why we can use a normal endotracheal tube with the help of this surface electrodes. So there are two types of intermittent nerve monitoring. Vis-a-vis, continuous nerve monitoring is a method by which we put a small electrode directly onto the vagus nerve. So it gives automatic periodic stimulations, and we can monitor the nerve EMGs on a real-time basis. So what are the parts of monitoring unit? It has got two parts. One is a recording side, one is a stimulation side. Now the recording side is the endotracheal tube, which I have mentioned. It's a pre-designed surface electrodes are there, which are to be kept in contact with the vocalis muscle. We have a recording side ground electrode, which is usually placed close to the surgical site, especially on a bony prominence, maybe on the acromion or on the sternum, and associated connections with the connector box. And the stimulation side is basically the monopolar probe. There is also a type of bipolar probe, but monopolar probe is most commonly used, remember, because it provides a diffuse current spread and helps to search for a greater area. When we are at a loss, when we cannot find the nerve structurally, maybe it is most common in revision surgeries because of the fibrosis and all. So we use a monopolar probe. We probe it at around the area where the nerve can be found, and that helps us localize the nerve. It has also got a reference electrode and a stimulating side ground electrode. So the monitoring looks like this. The setup of the OT looks like this. So the EMG tube is at the top. It gets connected with the connector box. We have the ground electrode and the reference electrode placed at the sternum, which are kept 1 centimeter apart. There's a stimulation probe, which is on the instrument trolley. The sister hands it over to the surgeon time to time to check for the nerve, and a monitor which is in front of the surgeon. So what are the checklists for an optimal IONM? Step 1 is to do a preoperative laryngoscopy, which I believe everyone in this room does on an OPD basis for a patient who is going to undergo a thyroid surgery. The step 2, most important, is the anesthesia checklist. So appropriate size endotracheal tube needs to be used. Lubricant jelly or lidocaine jelly needs to be avoided. Use of short-acting neuromonitoring neuromuscular agents, and after giving the final patient position for the surgery, the anesthetist once again need to check whether the vocal cords are in contact with the surface electrodes of the endotracheal tube. Medications and mechanical suctioning are to be done so that there is no pooling of saliva near the electrodes. And after intubation, the neuromuscular blockers need to be avoided. However, if we are doing it for a cancer surgery of the thyroids and we need to do a neck dissection, we can allow the anesthetist to give another dose of neuromuscular blockade before we finally move on to do the thyroid. And a proper depth and plane of anesthesia needs to be maintained. So next comes, which is the step 3, is the neurophysiologist's checklist. So once everything is set and done, the neurophysiologist asks the surgeon to tap with his finger on either side of the larynx, and they check for the completeness of the circuit, because on tapping on the larynx there will be a EMG monitoring, EMG waves on the monitor, and electrocautery unit are kept at a distance away from the system because of artifacts. So setting up for the IONM, so a low impedance of less than 5 kilo ohms suggests a good electrode and a patient contact, and an impedance imbalance of less than 1 kilo ohm between the two sides is allowed. The stimulation probe current should be kept at 1 to 2 milliamperes with a pulsatile output of 4 hertz per second. The amplitude of the waveform should be kept between 100 to 1500, and in general, an amplitude of more than 250 is highly suggestive of an intact functioning nerve. And the surgeon should have a visual access to the monitor, and the audio signals, the auditory signals should be kept loud enough. So what is the surgeon's checklist? The surgeon basically checks 4 things. So number 1 is the V1. So what does V1 mean? V1 mean once we start a dissection, suppose on the left side, we need to identify the left vagus in the carotid sheath. We use the monopolar probe on the vagus nerve and monitor the signal on the monitor. So this helps us to give an idea that whether the entire system is in a proper circuit. So number 2 is at the start of dissection, when we identify the recurrent laryngeal nerve in the tracheoesophageal groove, we need to again see for the EMG amplitude of the recurrent laryngeal nerve. And this is also kept on a note. So at the end of the dissection of that particular side of the thyroid, we again check for the recurrent laryngeal nerve signal and note it and compare it with the initial, which is the R1. And after everything is done, when all the hemostasis has been done, proper irrigation has been done, before closing the neck, we need to see again for the vagus, which is called the V2. So we need to remember, so why these values need to be noted down. Because if there's a 50% decrease in amplitude or a more than 10% increase in the latency, it suggests that there has been a nerve damage. And after all, even after all the signals are intact and not less than 50%, we need to do a post-operative laryngoscopy in all cases, which can be done the day after or within a time frame of at least 2 weeks. So during surgery, what is actually a loss of signal? So it has been defined by the International Nerve Monitoring Study Group as a no or a low amplitude of less than 100 microvolt when stimulated with a current of around 1 to 2 milliamperes, and in the absence of a laryngeal twitch on the ipsilateral vagal stimulation, in a scenario when the initial EMG activity has been more than 100. So what is a laryngeal twitch? So laryngeal twitch is when we place our finger on the cornu of the thyroid cartilage and we stimulate the vagus nerve, we will feel the twitch of the posterior cricoarytenoid muscle. The larynx will move. So this is called a laryngeal twitch. So I'm not going into the details of the loss of algorithms and all. So we need to know about two things, which is types of loss of signal. It can be type 1 and a type 2. So type 1 loss of signal is basically a segmental loss. So the electrical signal is lost at a specified point on the nerve, but it is present further down. So it indicates there's a localized injury in the form of either a compression or an inadvertent clamping or a traction or a thermal damage. And type 2 is a diffuse signal loss along the entire nerve, including the vagus nerve, at the extralaryngeal portion of the recurrent laryngeal. It is a more global thing, but it has got a better outcome than the type 1. So I'll skip these two. So what are the incremental values? Other than recurrent laryngeal nerve, what does it help to identify? It helps us to identify non-recurrent laryngeal nerve, which is very rare. Its incidence is 0.7% on the right and very less, almost negligible on the left. So how do we know there is a non-recurrent laryngeal nerve? So we will get a vagal stimulation very high up in the vagus, above the level of the thyroid cartilage, but it will be absent low down, and there will be a lower latency less than 3.5 seconds. So these will all be given on the monitor. So remote access, so rather than calling it a robotic thyroidectomy, its better terminology is a remote access thyroid surgery. So what is a remote access thyroid surgery? When we do a thyroid surgery, by not giving a cervical incision, but we approach the thyroid from extracervical sites. So these can be from the breast, these can be from the axilla, this can be from the retroauricular approach. So why was this need for change? The need for change was a patient dissatisfaction with a visible scar on the neck. So the approach and technique, so approach is the way by which the thyroid gland is encountered, medial to lateral or supero-inferior, and the technique denotes whether we use an endoscope or a purely robotic system. So the remote access methods which are most commonly used these days are number 4, which is bilateral axillobreast approach or the BABA approach, the transoral, which my previous speaker has already mentioned, and a retroauricular facelift approach. So the indications, there are no specific indications for doing a robotic thyroidectomy except for scar discomfort. What are the contraindications? The contraindications are a big thyroid nodule, presence of multiple central compartment nodes or lateral neck nodes, past history of surgery in the neck, past history of radiation in the neck. So I'll just go on to the BABA approach. So this was initially done by Ko et al. In 2007. Helps in optimal visualization by adding an extra axillary port, gives a better exposure. It's cosmetic, and central compartment dissection is also possible. So this is the robotic thyroidectomy system, the Da Vinci system 4th generation, which has got 4 arms and a console where the surgeon sits and operates. So the advantages of a robotic surgery are minimal access with minimal external scar, less postoperative pain, reduced hospital stay, 7 degrees of freedom of movement of the robotic arms, and has increased precision and vision for the surgeon. So robotic surgery has been found to be safe as compared to conventional surgery because there is no difference in recurrent laryngeal nerve palsies, there is no difference in postoperative hypoparathyroidism, the lymph node retrieval has been found to be adequate, there is no significant difference in the postoperative pain scores, the voice quality remains the same as compared with the conventional open thyroidectomy. The retroauricular facelift approach is basically the incision that we use for a parotid. It's a modified Blair's incision along the hairline. The flaps are elevated in a conventional fashion, and once we reach the neck area, we use either the endoscope or we dock the robotic arms and do the thyroidectomy from a supero-inferior approach. So the advantages are the flap distance is shortest and CO2 insufflation is not required, and the disadvantages are the thyroid lobe is viewed from the top down approach and the access to the contralateral lobe is often very difficult. So the transoral approach initially started by giving a sublingual incision, and on a later date it has been modified and we put transvestibular approach. So we take 3 incisions in the vestibule of the mouth, one in the midline which is around 1 centimeter and another 2 5 millimeter, a little apart from each other on either side. We introduce our scopes and we reach the thyroid level and we elevate a subplatysmal flap and approach the thyroid from the upper pole. So the disadvantages of a oral approach is a craniocaudal approach is a new thing to the conventional head neck surgeons, is technically challenging. So this can be your short note, and the potential complications are a mental nerve injury, a chin flap perforation, a commissure tearing, and skin dimpling in the midline of the chin. So I end here. I will not be discussing the parathyroid adjuncts. I'll ask Dr. Harsh to continue, and
I will just take 2 minutes to talk about molecular diagnostics in thyroid and just touch upon immunotherapy. From the molecular principles, these are the technological advancements that you heard of, right? You have to know about robotics, you have to know about stereotactic navigation, you have to know about minimal access, all of that. From the point of view of molecular diagnostics or moleculars in head and neck, of course we must definitely know what is the cancer, the field cancerization effect, the molecular principles of the field cancerization effect, the cancer pathways for normal like tobacco as well as HPV related cancer pathways at a molecular levels, these will be asked. Apart from that, if we talk about targeted therapies, you must know about the action of all the chemotherapy drugs. Especially, special importance are cetuximab, which is an EGFR antagonist. You also have the tyrosine inhibitors, that is the lenvatinib and the sorafenib. So these are important drugs that you must know of, which is being used nowadays. In workup of a thyroid nodule, molecular testing is of very important role, especially when you have the Bethesda 3 or 4. In those tumors, it is very much essential because it helps to identify which nodules actually ultimately need surgery. Normally, Bethesda 3 and 4, we subject them for a diagnostic thyroidectomy. So instead of that, you can run a molecular test and identify the presence of whether this does harbor any tumor mutations, which can then help you make a decision. These are important markers for thyroid. I'm just going to list them. You can read about them in detail. Most important is the BRAF. BRAF, remember, is again also important for melanoma. So don't confuse the BRAF of thyroid with the BRAF of melanoma. The mutations are different. So this is the BRAF, and with that you must know the BRAF V600E mutation is the most important one. You also have the RAS mutations, the RET PTC, which is more important for medullary thyroid carcinoma, and you must know about the TERT promoter. Out of all of these, the prognostic factor is only with the TERT. So now, what are the molecular markers that we have? All these different molecular markers are there, but what we nowadays do is we have moved from single markers to mutated gene panels. The first panel was the 6 gene or the 8 gene panel. Then you had the microRNA expression panels, which could account for 167 gene expressions. And after that, we now have a combination of the 6 gene mutation or the 8 gene mutation panel and the miRNA expression, and this is known as thyrosequence. So thyrosequence 3 is the latest, and that actually contains both the properties, a rule-in test and a rule-out test. So when you're writing your answer, you must list what are the common mutations, you must list what are the rule-in tests, what is the meaning of a rule-out test, and we will be sharing these important landmark papers or review articles over email subsequently. This is a very good review article on molecular markers in well-differentiated thyroid cancer, authored by Indian authors only. and it is very simple to read. So right now, the thyro sequence, you must know what is the diagnostic ability. Diagnostic thyroidectomy is avoided. Must remember these percentages. In 51% of patients, it is actually useful. These are the recommendations as per ATA. I will not go into that. The other place where molecular in thyroid helps is if you have a mutation in the PDTC or the anaplastic tumors, definitely again here the BRAF and the RAS mutations, then you can choose your targeted therapy accordingly. So nowadays, inoperable anaplastic, inoperably poorly differentiated thyroid cancers, you can run molecular tests, and if the mutation is present, you can give targeted therapy accordingly. I will just go briefly into the immunotherapy. So how does a normal head neck squamous cell cancer evade your immune system? There are three mechanisms. Most effective is its action on the tumor infiltrating lymphocytes. Whenever you have a tumor, you have a surrounding tumor microenvironment that is called TME. TME has a lot of lymphocytes, specifically the CD8 T cells. The CD8 T cells express PD-1 on top of their cells. And once, what happens is, to evade the body's immune mechanism, the squamous cell cancer cell comes and inhibits the PD-1 cell. If it inhibits the PD-1 marker on the T cell becomes exhausted, the T cell cannot act. So now we have produced antagonists which act on this PD-1, PD-L1 complex, and most commonly we have the pembrolizumab and nivolumab. These are the two important drugs. There were two important trials. You must know the name. Checkmate 141 for nivolumab and the keynote trial, keynote 012 for pembrolizumab. We are not going to go into the details, but you must know where it is useful. So both these drugs were approved in 2016. They have changed the way that chemotherapy happens in recurrent metastatic setting. You must remember, in patients who have not received cisplatin prior and those which express a high level of PD-L1, the best option in the recurrent metastatic setting is immunotherapy plus chemotherapy. Or you can do a cetuximab based chemotherapy. In patients who already have received cisplatin, then irrespective of your PD-L1 expression, immunotherapy can work. This is a brief algorithm. I'm not going into the details, but this was briefly about immunotherapy for you guys. So molecular is very important, and be sure to go through all these topics. I'll end here and we'll share important articles and review papers with you to read. Thank you.